that most of the exams we keep one or two ERCP films for interpretation, because that obviously, as we understand, that most of the gastroenterologists keep doing ERCP, and for that immediately most of the time radiologists will not be available. So literally that becomes bread and butter for the uh, uh, gastroenterologist. So every gastroenterologist must know how to interpret radiology and particularly ERCP. So that I was talking about, that you do pure radiology or you do clinical radiology. So for pure radiology, I think participants have to mute. So pure radiology, you don't look for much of the clinical details, and you interpret the things based on the image characteristic and data. So as a gastroenterologist, most of the time we practice clinical radiology, which is supposed to be much easier and possibly much more accurate. So here, this is ERCP. ERCP I was talking about, there we have two scope positions. One is, this is position which you recognize so well. This is a standard scope position or the short scope position. In the short scope position, this is the position, and the bile duct will always cross the scope. So that is how we are. There is, and then there is some intrahepatic duct dilatation, and there is narrowing. So a stricture in at any place you don't recognize by narrowing. A stricture is identified by upstream dilatation. So what you are seeing here, the upstream, what is below. So upstream ducts are supposed to be tapering, so that, but it is not. So we will interpret as dilated duct. Gallbladder is not opacified at all. So gallbladder is not opacified. So we presume that either it is a status post-coli or the cystic duct is blocked. But I'm showing you this for slide for different reason. That here what you see, this is the entry point, papilla, and then you see this much distance, which is the common duct, and then the two ducts separate. So that is the criteria for anomalous pancreaticobiliary junction. So that is a different articles have taken different, and the cutoff varies anywhere between 7 millimeter through to 12 millimeter length of common channel. But there is additional criteria that if the it is ectatic, then also it is taken as anomalous pancreaticobiliary junction. So there are two very strong association of anomalous pancreaticobiliary junction. One is carcinoma gallbladder, and the other is choledochal cyst. This is actually a case of carcinoma gallbladder. Here GB is not a specification because the cystic duct is blocked. So this is another patient. This patient had presented, I told you, clinical radiology. So had 5 years history of pain abdomen. So this is a typical scenario where we will suspect that there is pancreatic pathology. And in the first slide, what you are seeing is that there is a duct going downwards. So any duct which is going downwards from your cannula position should not be pancreatic duct. Pancreatic duct should be going obliquely and crossing the vertebral body. So that is very important. So when initially we saw, this should not be taken as pancreatic duct, main pancreatic duct, I mean. So this is what basically uncinate process branch of the main pancreatic duct. So here our manipulation should not be in this direction. It should be manipulation in this direction. So that is what has been done, and ultimately pancreatic duct is opacified. And what here you are seeing very interestingly is the dorsal duct is also very prominent, which is so common commonly seen in chronic pancreatitis and age-related pancreatic atrophy. So that is very commonly seen. So in MRCP, this can be misinterpreted as pancreas division, which we have seen many times, that because of the prominent dorsal duct, ultimately interpretation and a stricture in the head region, it is misinterpreted as pancreas division. The things get clarified on ERCP. So here you see the same patient, that wire has been passed, And when we were taking the accessory class, then I was talking that always, because core and coat of the wire we talked, and that time we were talking about that core is made up of nitinol, and I said that there are several good properties about the nitinol, but two bad properties of nitinol, or undesirable property rather than bad. So one is poor radiopacity, and the other is poor resistance to acid. So they tend to nitinol wire tends to break in the presence of acid. So acid tolerance is poor. So here you see the shaft of the wire is very poor radio opacity, but tip 5 centimeter, as we discussed in the jag wire and then also in VG glide, it is very briskly radio opaque. So this is why, this is because the companies provide extra material there. So either it is platinum or tungsten, and in Jaguar we had discussed that it is tungsten loaded. So that is very important. But you see one additional point here. Okay, so you can consider this also extension of your instrument class. So here you have like the tip, which is tungsten loaded tip, but here. So this is the point marks that from where the floppy tip starts, floppiness starts. So area ahead of this should not be used for dilatation purposes and stent, because this will provide hardly any support. So that should be taken care. Here we have two guide wires placed, and obviously why do place two guide wires in the main pancreatic duct? Because we want to place two stents. In the setting of chronic pancreatitis, the guideline is to that as much as you can place, the target will be 10 to 14 French. So here 7 French stents have been placed. So that will result into resolution of stricture. So another patient, this patient also had history of pain abdomen for 5 years and jaundice for 1 month. So obviously you understand that again, one of the differential diagnosis will be chronic pancreatitis, but the patient is also jaundice. So we will have to study the bile duct also. So prior imaging showed that there is dilated bile duct. So this is again showing changes of chronic pancreatitis. So if you remember, there is changes are graded according to a classification system where we say it mild, moderate, severe, and equivocal. Equivocal is the initial changes are seen in the side branches, and if is up to 3 side branches are clubbed, that is called equivocal changes. So the pancreatic duct branching is always at right angle, in contrast to the bile duct branching, which is always acute angle branching. So you see clubbing of those side branches, then equivocal up to 3, more than 3 is taken as mild. And if changes starts in the main duct, but no dominant stricture, then it is moderate changes. And if you have multiple strictures, chain of lake appearance, calculi in the main duct, then severe changes. So this is grossly dilated duct. There is some suggestion, there is irregularity of duct, and there is suggestion of a stricture. This duct is dilated because here we have a stricture. And again, a stricture, what we do, a stricture dilatation and putting a stent. So this stricture was dilated and a stent has been placed. But most important point, this patient was also jaundice. So we need to see the bile duct also. So the same patient we have here. So pancreatic stent is in place. This is 10 French, by size you can recognize. And then you have a stricture. And I told you earlier that how do we recognize a stricture? We recognize a stricture by virtue of upstream dilatation. It is not the segment, narrowed segment will not give you diagnosis of a stricture. It is the upstream dilatation which is important to be there. Which
Recording stopped.
Which must be there to diagnose a stricture. So here we have a stricture. Now we have to describe the characteristic of a stricture. So if you see, this is centric stricture. So it is tapering from both sides. Mucosa is absolutely smooth and there is no evidence of soldering. So soldering, it should have been like this. So it will have overhanging margins. So it is not that. So it is tapering margin. So this is typical characteristic, what is called benign stricture. And this is intrapancreatic portion or lower third of the bile duct. Why? Because this scope is marking the first part of the duodenum. This shaft is marking first of the duodenum, and this is the lower part. So below that there will be pancreas. So this is in intrapancreatic portion. So this is characteristic of benign biliary stricture involving the lower third, and most likely because of chronic pancreatitis, and the changes of chronic pancreatitis we have seen already. So there is not much of problem. Now you see this patient. So this patient presented with pain abdomen for 4 years and has raised LFOS for 5 years. So this is typical scenario where you will consider benign biliary stricture again. So what you see in this patient, so that this duct is little dilated because it is diameter is comparable. How do you measure the diameter? You compare with the scope. So scope is around taken as 11 to 12 millimeter, depending on the different brand of scope, and you compare that. Because depending on the magnification, this will change. So you always compare with the scope. So here around 12 millimeter, common hepatic duct and upper CBD. So this is mild to moderate dilatation. So here what you are seeing, there is tapering, and again middle and lower third are appear to be narrowed, but here it seems on the face of it that there is contrast extravasation, but no, this is false tracking, because you see this guide wire going here. So this is the margin of CVT, and this is not the contrast margin which you are seeing. So this is, there is no extravasation, and this is actually benign biliary stricture. And if you see here, then what we have done, so we have placed a metal stent out here. So you are able to see, and you see that upper part of the metal stent is broad, has fully opened up, but lower part is still narrowed. So anybody will like to answer? What will we do? Will we doing now? So no answer. Okay, fine. So what happens that metal steps open, stents open in two steps. One is immediate opening. That is because of the constraint. And yesterday we were in the last talk, last class we were talking that this nitinol has a very, very strong thermal memory. So on as it achieves a temperature of 37 degree, 38 degree, the core temperature of the body, so then it starts taking the original shape for which it has been designed, and then it starts exerting the radial pressure. So the second step of opening, which is very, very gradual, and it may take up to 72 hours. So if you see narrowing like this, you don't immediately jump and go with the balloon dilatation. You wait for 72 hours, and most of the time the stent will open up in 72 hours. If it doesn't open, only then we go ahead second time and do the balloon dilatation. So again, this is benign biliary stricture. There is no bile leak. The tracking which was is false. So now what you are seeing, this is prior to injection of contrast. So what you are seeing out here is radio dense lesions. So these are basically calculi, which are seen in the region of pancreas, because here at the papilla we are cannulating. So this is the region of pancreas. So then again, then we have injected contrast, and we see that some sort of duct is opacified, but not able to make out. Looks like main pancreatic duct, because this is not going down. So as I had explained you, that uncinate process branch will go towards the lower side. So on further injection, we could pass contrast across those stones which were there. So they are occupying the head and neck region, and the upstream duct is dilated. And again, you are seeing the tungsten loaded tip of the wire, and then the marking from where the floppiness of the wire starts. And again, stent has been 10 French stent has been placed across a stricture, which is the norm. And here you are able to see the calcification. So then you have this. So this is semi-long position of the scope. So why this is semi-long position? So normally we don't like to work in long and semi-long position because scope handling of accessories becomes poor, maneuverability becomes poor. So that's why. But here we have deliberately, scope has been pushed into semi-long position because the portion of the bile duct tends to get opacified because of scope will be passing through this area. So then we will not be able to appreciate this stricture. We can suspect this stricture by virtue of the upper segment which is dilated, the upper CBD which is dilated, IHBR which is dilated. So this is a short stricture and there is evidence of soldering. So this is the typical scenario where we will consider malignant stricture. And also you see there is history of only 2 months and this is painless jaundice. So typical scenario for, and you see this is eccentric stricture and there is evidence of soldering distally. Proximally the soldering is little bit not so prominent. So what we will do, we will take brushings and you see the brush. So brush, there will be tip of the sheath and another radiopaque marker, which will be at the tip of the brush. So the two radiopaque marker must cross this stricture before we open up. Because if we open the brush below that, then there can be false tracking and there can be perforation. So this has to cross that. So you can see that the tip is there and then we have opened after crossing and then we have opened up and this is what is the brush, the opened up brush. After that the brush will be pulled down and brushing, it will take the brushings and then we close the brush. So 3 times we have to repeat, then we have to dilate the stricture and put a stent. So here you see that 2 stents have been put. Both are 10 French stents. One is one is double pigtail, and the other is a straight stent. Okay, so that is. So another case again, painless jaundice for 3 months, and again by now you are very conversant. So you see there is tapering a stricture. So this is again you see this is this marks the first part of the duodenum. So that is uh, uh, that is intrapancreatic stricture. So again benign biliary stricture, most likely chronic pancreatitis, and here 2 stents have been placed and still you can see one guide wire. So possibly maybe third stent will be also placed. So here what you are seeing a cholangiogram. You see the guide wire here, but there is no definite filling defect. There is one suspicious filling defect you see in the left duct, but in the CBD. So this is there is very common. This patient had presented with pain abdomen, fever, jaundice for 7 days, typical scenario of CBD stone or with cholangitis. So if you give undiluted contrast, so it is very easy to miss the stones there. So there are some special techniques which are required for demonstration of stones. The most commonly which is required, which is described in all the books, is you use diluted contrast. So 33% to 50% saline you add to contrast, and that contrast you will use, then the stone will be visible, because otherwise dense contrast behind or in front of stone, that makes it invisible, which is happened in this situation. The other two techniques are either manipulation with the manipulation with the balloon, which will move the stone and stone will be will become visible, or manipulation with the sphincterotome or the guide wire. So the moving stone will be better seen. So what you see here is balloon. The contrast has been diluted, and if you have put a dense contrast, then obviously you don't try to take out that contrast. You just push some saline and wait for a little time, so it will get mixed up, and then you can see these stones serially lined stone here. So multiple stones which were completely missed on the initial cholangiogram. So the learning point is that for when you have suspected CBD stone, there are two precautions. One, use the diluted contrast, or if the initial contrast injection uh, same to do the contrast. The second precaution we take, we always start injecting from above, not from below. Balloon sphincter. So this is balloon sphincteroplasty which is being done, and this you see too many stones out here, and then you can see the stones is being extracted. So are you able to see clearly? This is video. So that gives you, that is how that when I was talking about that by manipulation of balloon, you will be able to see the stone clearly. So that is how it goes like, or this is how it looks like. Okay. So now again, what you are seeing again in the semi-long position of the scope. So you see by now you recognize the semi-long position. Long position is will go still further down. So you have the bile duct cholangiogram, you have the pancreatogram, but what interestingly, what you have a dilated pancreatic duct, grossly dilated, because this is 12 millimeter, so it is at least 10 millimeter dilated duct or 12 millimeter dilated pancreatic duct. So pancreatic duct diameter is 3 millimeter, 2 millimeter, 1 millimeter head, body, tail on the MRCP and non-dilated. In ERCP, and in elderly population, more than 65, 70 years of age, you can use 1 millimeter more, because with age, the diameter tends to increase. So this is grossly dilated duct, but what you see most importantly is there is a stricture here, and there is ductal disruption, and the contrast is leaking. So this is going into some obscure area, undefined area, and this is very, very irregular. So this is ductal disruption, and this is leading to ascites with high amylase. So that is pancreatic ascites. So obviously what we will place, we will put a stent, but this stricture is too tight. So we are dilating this stricture with a balloon. So you can see the contrast out here. You can see the balloon out here, and it will be dilated. And then our post dilatation, what we do again, two guide wires have been placed. So two stents will be placed. So 7 French into 2, so 14 French stent. So this is the ductal disruption. So this you can see, you see the metal stent out here. Okay. And then this is the short scope position, and the wire is not crossing the duct and crossing the vertebra. So you know this is pancreatic duct anatomy. So there is selective pancreatic duct cannulation which has been done, and then guide wire is looping. So most likely is into some cavity, some sort of cavity, and then contrast you are seeing here is very irregular manner, and through the metal stent it is going into some another area. So this is basically cystogastrostomy, walled off necrosis, cystogastrostomy. Cystogastrostomy has been done, and contrast is entering into the stomach cavity. So we have to stent this to for the proper healing of the cystogastrostomy. And can anybody make a diagnosis on this? So this is again what I have been teaching you, that short scope position, and the guide wire crosses and doesn't cross the vertebra. So this is typical position of the bile duct. So selective contrast-free cannulation of the bile duct has been done. And again, you are seeing the from where floppy tip starts, and then you are seeing the tungsten loaded tip. And what you are seeing is a meniscus thing out here at the level of CSD. And what is this? The diagnosis is very, very obvious. This is Merijie syndrome. But what is important, it is very, very important to read the whole film. So in Merijie syndrome, the stone is impacted in the cystic duct, producing uh, producing a stricture and upstream dilatation. But what is most important, normally a stone is above. Here we find a stone even below that stricture, that impression thing, and then we have another stone. So it is very important to realize and clear this stone also when we are treating this thing. And because most of the diseases will require surgery. So stent has been placed for palliation, and subsequently patient will undergo surgery. So again, the guide wire I will ask you to see, this is tungsten loaded tip, and this is the point which marks the start of the floppy part. So again, the contrast has been injected, and what you are seeing is a pooling of contrast, extravasation of contrast. So there is ductal disruption, and guide wire doesn't seem to be entering the upstream duct. So this is again acute pancreatitis, 11th week of illness. So this is ductal disruption, most likely walled off necrosis at that level. But it is very important to have the complete cholangiogram and complete pancreatogram in almost all patients. So what you are seeing that in addition to that, which is a walled off necrotic cavity, there is another disruption out here from the mid-body level. So it is very important, unless you make out all the disruptions and bridge them, their recovery, you will not get the optimum result. So here what we have done, that ultimately guide wire entered into the necrotic cavity. So that gives us support so that the floppy part we will accommodate there. And the stiff part we will use for placing a stent. So 7 French stent has been placed here. So here acute pancreatitis, 10th week of illness, and what you see, again, the pancreatic cannulation has been done, and the guide wire you are seeing here. What interestingly, what you see, you don't expect anything to go below that. So this is ductal disruption, and it is tracking. Okay, so there is ductal disruption, and this there is a PCD, percutaneous drain, already in place. So that tip is also in cavity, and if you see closely, that it got contrast has entered into the large cavity. So if you don't see carefully, you will tend to miss this part. So ultimately, the guide wire has entered into this cavity, and the floppy tip, the floppy part and the tungsten loaded part has gone, and then we are placing a stent at the mouth of ductal disruption. Okay, so this stent has got at the mouth of disruption. Sometimes we go into disruption of the cavity also, so that will result into healing. So here it is a post-operative patient. You can make out that there is a T tube in situ, and with T tube in situ, when do you do ERCP? So most of the time you will do cholangiogram, T tube cholangiogram, and then if there is any residual stone, that is the purpose of putting T tube, and then you will do ERCP for stone extraction. So here again, very dense contrast has been put, and stone is not visible. So to make that visible, again, same technique that you put some saline inside, dilute the contrast, and then you are able to see there are multiple stones there lying there. So that was extracted, and ultimately for some time we will put a stent and remove the T tube. That is how it is done. So these are the different patients. So basically, these patients presented with acute cholangitis, and then you can see that cholangiogram has been obtained, and hugely dilated duct with the tapering lower end and huge stones. So this is 12 millimeter diameter of the scope. So you can see that is almost 20 millimeter plus size of the stone. So it will not be possible to extract. So either you do lithotripsy or you do spyglass and break the stones with laser lithotripsy or mechanical lithotripsy and some sort of lithotripsy. But obviously in the acute of cholangitis, you don't do any such procedure. You will just drain and wait. So what has been done is actually the nasobiliary drain. So either stent or nasobiliary drain. Earlier we used to use nasobiliary drain more, but now more and more stent we use. Again, very large stone, and you can see that this is 12 millimeter size scope, and it is almost twice the diameter. So almost 2.5 centimeter size CVD stone, and with a very narrowed lower duct. So this will also require breakage of a stone. So breakage, there are different ways. Some of the methods we talked just now, that we can do either mechanical lithotripsy, laser lithotripsy, electrohydraulic, but another method is ESWL. And for ESWL, you require nasobiliary drain, because that localizes the stone fluoroscopically. So most of these CVD stones are not radio opaque. So one needs to put contrast, and stone will be localized as filling defect as it is seen here, and then shockwave will be given and it gets fragmented, and subsequently we will do balloon dilatation and extraction of the fragments. So this is again similar acute cholangitis patients, and you can see different degree of filling defects in the bile duct, hugely dilated duct, more than 2.5 centimeter. So we'll require lithotripsy, and that again another patient of acute cholangitis, very large stone. And when you see large stone, you can try dormia, but such type of stone extremely unlikely to come out of dormia. So most of the time will require lithotripsy. So some sort of lithotripsy will be done. So little bit we will cover other type of radiology. So this is conventional radiology, which is barium study. And barium study is very sparingly used now, but one situation where it is still useful is in the situation of leaks and esophageal strictures. So esophageal strictures, it is always preferable to do. So this is typical scenario, different patients, not same patient. So this is anastomotic stricture. So post-operative patient. So even the anastomotic segment has narrowed, but in addition has a very tight anastomotic stricture out here. So in other patients also. So this you see, this is post-corrosive patient, and what you see is stomach is fully loaded, but contrast doesn't seem to be going further. So it is completely narrowed. So this you will interpret as gastric outlet obstruction, antral and duodenal stricture, most likely secondary to corrosive ingestion. And then you see the length of the stricture by this is CT scan of abdomen. So there you can see, and then we had this is from one of our paper where we used diathermy for negotiating this stricture. Routine guide wire was not going, and then ultimately dilated with that diathermy. This type of picture you will commonly get in exam. So this is hydatid cyst of liver. So there is classification available from WHO and Garvey's classification. So one should become acquainted with the classification system, most commonly because WHO classification is more acceptable. So WHO classification one should remember. So this is type 1, 2, 3, 4, 5, 6 cyst. So type 1 will be simple cyst. And so it will have a differential diagnosis like unilocular cyst or simple cyst. The differential diagnosis will be simple cyst versus hydatid cyst. So if serology is positive, then we will label as hydatid, or scoliosis seen on aspirate, which will be routinely is not indicated. But when there are multiple daughter cysts are seen, so then virtually it becomes diagnostic, and membrane will be seen very clearly, more clearly on the ultrasound and contrast ultrasound. So there, this is type 2 cyst, and then again multiple membranes and multiple daughter cyst with undulating wall membrane. So this is type 3 cyst, and type 4 is calcification in the wall. And then the lesion also starts getting calcified. So type 5, and then type 6 is the whole lesion is calcified. This is dead parasite. So when you see hydatid like lesion in liver, one should always try to classify according to WHO. So if you remember only, then you will be able to do. So here what you see is a cystic lesion that is very important. So obviously this is hydatid cyst. All the membranes are not so clearly seen, but what you are seeing is a dilated left ductal system and dilated right ductal system and intrahepatic ductal dilatation. So whenever you find ductal dilatation or CVD dilatation, so then you always suspect that there is biliary rupture. So here you see the bile duct is dilated and it contains membrane into that. So again, you have a hydatid cyst, again ducts are dilated, and then there is a membrane in common bile duct. So this is post of patient of hydatid. So again, the you have venous catheter in the hydatid cavity, which is communicating with the duct, and in the duct, lots of debris is lying. So this is common hepatic duct, common bile duct. So there the T-tube drainage, the T-tube is lying in place, and then you have filling defects here. So obviously this patient will require ERCP, will clearance of the duct, and then placement of a stent, then T-tube can be removed, and subsequently as drainage will decrease, this tube can be removed. So ERCP will be therapeutic. Here, for bile duct biliary communication for hydatid cyst, the ERCP remains gold standard. So here what you see, that you see the everything, all the biliary strictures are very stretched. So this is a huge cyst which is out here, and which is lying there. And then there was biliary rupture, and this is biliary dilatation and so again, you see two types of, these are different sets of patients. So you see that there is cystic cavity and lots of irregular appearance, filling defect inside that. This is called crumpled paper appearance. So like imagine you take a newspaper, crush it into the hand and make a ball of paper, and that you'll leave there. So this is typical crumpled paper appearance. So this is hydatid cavity with the lots of membrane lying there, and which is communicating with the bile duct. And this is ERCP study. So a scope is seen here and here. So you can make out, and the duct is dilated, and this is cystic duct. So okay, so that you can make out. So obviously patient will require a sphincterotomy clearance, and most of the time we place either a stent or nasocystic drain into the cavity, and try to extract the membrane as much as possible. This is another patient, and again very irregular cavity is filled out here, and lots of filling defects, irregular filling defects are seen in the duct. So that will be seen. Again, same patient. So that is cavity is seen here. So what we do most of the time, that if you see a hydrated cavity out here, and lots of irregular filling defect in the bile duct. So what is this irregular filling defect? So this irregular filling defect is nothing but membrane, and then we try to take out this membrane using the balloon. So you can see the inflated balloon out here, and this is tracking of contrast because on the crumbling membrane. So this is the typical appearance you get, and what you extract, membrane looks like this. So this is the membrane which is being extracted. So another patient, so if you see the membrane lying at papilla, so sometimes when you are doing endoscopy or ERCP, you see something like that. It's upfront, you will suspect that papilla is bulky, and then you see something hanging. So this is membrane. And ERCP, the grossly dilated duct with irregular filling defect and a large cavity filled up. So a sphincterotomy done, clearance done, and then a stent will be placed in those patients. So will be done in a staged manner. So these are the hydatid membrane when we extract. This is how it looks like. So remember this appearance, and this is the balloon is seen, which is used for extraction of these membranes. So this is less bile stent. So this is looking little whitish. Otherwise, this is the papilla. So another post-operative patients. So what we are seeing is percutaneous drain, lots of filling defect in the bile duct. So again, very, very irregular, not taking any particular shape or size. So again, it is membrane which is lying there, and that is the cavity which is getting filled. And this patient had the ruptured into the pleural space. So you can see this is the dome of diaphragm, and it is going across diaphragm, and it is entering into the pleural space. So that is how, and this is one particular odd case where you have peritoneal spillage and lots of hydatid cysts in the peritoneum. So multiple cysts in addition to liver cyst, which we are seeing. Little bit of uh, conventional radiology. So this is barium. As I told you earlier, that we less and less we are using barium studies now, but we use still for and leaks and strictures. These are the situations where we still use, and here we have anastotic strictures, and then we have a neoesophagus, which can be either colon or which can be stomach. So by virtue of by seeing the folds, you can see if you are seeing the longitudinal folds, most of the time it will be stomach, and if you are seeing the transverse folds, then it will be colon most of the time. And here what you are seeing, it is again corrosive strictures. So the upper esophagus is grossly dilated, little tortuous, but lower esophagus is narrowed. Typical beaking you are seeing. Beaking means always benign. There is no evidence of soldering out here, and the mucosa is very irregular out here. So that suggests basically that suggests ulceration or mucosal destruction. So which is seen in many times. Sometimes you see small cavities getting filled up, which are the dilated ducts in that segment. So that is on. This is barium meal study. So what you are seeing here is hardly any contrast spilling after some time. A small amount of contrast is passing, but there is a long antral stricture. So this is barium stricture which is seen, and again very similar patient. So you have a long antral stricture out here, and these are called pseudodiverticular. Okay, so these are also diagnostic of benign strictures. So pseudodiverticular are less commonly seen in malignant strictures. They are more commonly seen in benign strictures. And here you are seeing irregular filling defect. This is not because of the mass lesion, but because of the gastric outlet obstruction, because of the food residue which you are seeing. So again, you are seeing another stricture here. You can see there is a metal stent, and you can try to make out which stent it is. So even in esophageal. So I will stop here. There are more slides of CT, TB versus Crohn's, but today I think we have had enough, and I will like to stop out here. So please guide on calculating length of biliary stents based on the cholangiogram. So this is very, very interesting question. So that is how I explained you that how to take measurement. So you have inbuilt reference, your scope, and you should always take your scope as a 12 millimeter. So then you have a reference in compare all other things. So that is how. Rule of thumb is from the primary confluence to the ampulla level, you take as 10 centimeter. So if you remember the length of CVD, so it can varies from 7 to 10, but for practical purposes, we always take 10 centimeter. So 10 centimeter, and then you can calculate. So the cystic duct joining is variable. So you always try to measure from the primary confluence to. So these are the two methods which I have told you. Then another method we use, we pass some of the devices, guide wire, sphincterotome, anything, and we are seeing radiologically the tip of the sphincterotome, and then we start withdrawing till the papilla, and then we take measurement. So that will also give you or to the lower end of a stricture and upper end of a stricture. So these are the different ways of calculating, measuring the length. So in any landmarks for sectoral that I'm not discussing, because for that I will have to discuss the segmental anatomy of liver. Only then I can discuss. So that is sometime later I will be doing. To differentiate between left hepatic duct with the pancreatic duct in ERCP. This I have answered you all already. If that your guide wire or the ducting this spine, this is bile duct. ठीक है, and anytime if it the vice versa happens, like the duct, pancreatic duct will not cross the scope most of the time, but if you are in long position, it will cross. So that's why I said that always in the interpretation of ERCP, you always see a scope position. But in that situation, the crossing will be different. So when it is crossing the bile duct, crossing the scope, and when it is crossing the spine, that differentiates. And then I told you that pancreatic duct branching is always at right angle, whereas bile duct branching is always acute angle branching. So branching pattern, if you see, because in the right bile duct, if you inject contrast, the other ducts will be uh, dividing, and then you can see what angle they are dividing. So these are some of the points which you take into consideration to differentiate it. In the rare circumstances where you have confusion between the left hepatic duct and the pancreatic duct, that happens rarely. Cholangiographic assessment of left lateral position during ERCP. So with the segmental anatomy, we will discuss that is will come much later. But for the time being, we are restricting to the prone position only. So that much only. So first we have to learn that, and then we will be doing. So any other question, anybody?